Mo ti bẹ̀rẹ̀. Ẹ sọ fún mi.
Ladies and gentlemen, we are about to start the next session, second lecture of this same seminar outreach. On behalf of our chairman of the DSO, thank every one of you for your patience, for your dedication, for your hard work since this program has started. We say a big thank you. So, in order not to waste much of our time, we'd like to call on board our lecturer. The lecture we have this afternoon is going to be Obstetrics Emergency in Rural Surgical today was born some years ago. He attended Ahmadu Bello University and he graduated with MBBS in the year 1981. He became a fellow in family medicine in the year 2005. He has several mission hospitals, Ifeoluwapo Specialist Kegbo Hospital Ibadan. And our guest lecturer is a trainer of in international interactions across nations, covering Africa and other events. Our lecturer is also a pastor in uh, UCH Chapel and also in Okegbo. He is
Hello? Okay.
he is not any other person than Dr. Okedare Amos Oluwafemi. Please, a round of applause for our guest lecturer as he is coming to the podium to enrich us with his wealth of experience in obstetrics emergency in surgical practice. You are welcome, sir.
Thank you very much. I feel highly honored by my colleagues and my contemporaries in this experience of rural surgical practice. I'm highly delighted that this association has continued to grow. I remember shortly before COVID, your outreach series that took place in Ibadan. I had the opportunity to come and give lecture, and I'm happy to let the house know that some of your aspiration has started to yield fruits. We were looking at ensuring could become like a the open university. Unfortunately, that has not taken place. But I can assure you that some of the materials we gather together during those years are what we have gathered together and is now being used in the Department of Family Medicine for what we now call the special area of interest. Family medicine and indeed all fellows in the West African College of Physicians and Surgeons are being encouraged to specialize. The situation in which you have, like it's going on now, gynecologists are complaining that people with MBBS are doing cesarean section. It will be a disaster if a nation is training a gynecologist only to come and be doing cesarean section. They are challenged them that is not your work. Your work is to be doing IVF. Your work is to be doing other very specialized things, and you should leave things that are basic for people with basic qualifications. So I'm highly delighted that this association has continued, and I want to continue to encourage us that yes, our time is here, and as it has happened in places like India, that what we are doing has become something that people can go and have a qualification very soon. Within in Nigeria, we have such a qualification. So once again, I would like to thank the chairman, the secretary, and my very dear friend also for all of you for inviting me to this time. I believe the next few minutes we are going to stimulate ourselves, knowing that adult education is not all like that lecturing, it's a way of interaction. So I believe that in a few minutes I will share my slides, and after that we can then into other interacting and sharing experience together. Next slide. We're going to be looking at this topic through definition of terms. The WHO Emergencies Obstetrics care, which summarizes what we can call the emergency obstetric care within the rural area or across the whole world. And then I want us to look at the major sources of maternal morbidity and mortality, and use that to look at what we encounter in our rural practices, and then be able to use that to guide ourselves in our discourse. And the highest, as we all remember, is hemorrhage, obstetric hemorrhage, then hypertensive diseases in pregnancy, and then we will go to obstructed labor, which is the next commonest challenge. Then assisted vaginal deliveries, which I can tell you that the obstetricians don't want to hear about it, and I can tell you that being having opportunity even to train some of their residents, I know that many of them don't know this. But you and me, we must continue to learn it, we must continue to use it, because it's recommended by WHO that we should still continue to do assisted vaginal delivery. And then the and the rural area, resource poor, even nations are resource poor. So also some areas of the nation are even more resource poor. And the characteristics that in resource poor environment, we can go ahead and have innovations. And I believe that part of what we can continue to do as we go on some of the issues that we have in practical life. What are the innovations that we can put in so as to help ourselves? And
Also from WHO and other sources, we can also define our term as an emergency in an occurrence of serious and dangerous nature, developing suddenly and unexpectedly, demanding immediate attention. And we can see one of the key things is for when such things happen suddenly, that we find opportunity to ensure that we solve the situation. As I said, it's important that we look at the WHO emergency obstetric care. In 2009, WHO set up what is called emergency obstetric care. And the components include, number one, the administration of parenteral antibiotics as well as anticonvulsants. Some of these things, they may not necessarily be critical for the doctor, but what we know is that in resource constrained area, as long as we can do some of these things, we'll be able to stem the tide of many of these obstetric emergency. Administration of intravenous fluid, the use of vacuum extractor and forceps for assisted vaginal birth, as I mentioned earlier on. Then manual removal of placenta. Then removing the product of conception following a miscarriage or abortion with what we all now know as MVA. That is the basic. And then they call the one that we add these two remaining one as the comprehensive emergency care, wherever you can do a cesarean delivery as well as you can give blood transfusion. And I believe that in most of our rural area, we should be able to do that within our facilities. And in some of the facilities, even if we cannot do the blood typing and blood cross-matching, I'm sure in most of our local area, there are private laboratory that can sort all of those out for us. And this is the summary of this. Outside of the circle is the comprehensive one, cesarean delivery as well as blood transfusion. And the basic one is within the wheel. Now, essentially, as far as WHO is concerned, you have completed emergency obstetric care as long as you can do all of these basic ones we are talking about. But I think for our level, let's go a little bit deeper. Yes? So, I feel like we should look at the morbidity and mortality pattern in obstetrics across the world. And if you look at the world map there, we will see that our own area of Africa and part of Southeast Asia are where we have 600 or more of maternal deaths per 100,000. And we can see the other places that they have less. Now, what are the common things that create all of this? These are what are listed. On top of it is severe hemorrhages. And in medical school, we'll be told that obstetrics is a bloody business. And on top is severe hemorrhage. Hemorrhage is the commonest cause. And I'm sure every one of us in this room, one way or the other, we've encountered women with obstetric hemorrhages. Next is infection. And then hypertensive emergency. Then complications of can be also be. And in antepartum, we have the component being placenta previa, different types, and then we have abruption. Abruption can be released woman is coming with abdominal pain, uterus as you examine becomes large, then because either alive or any of the osteotics, even including our misoprostol of today. So for that reason, what you need to do is to go in immediately, deliver the baby, and if possible, ensure before you even go in, you get enough blood, because here you may have severe postpartum hemorrhage, which can also cause even depletion of prothrombin as well as other platelet factors. So next in hemorrhage after the antepartum one is the postpartum, and I'm sure many of us too have had opportunity for this, but for the purpose of remembering, you can use 4 T's to remember, and you can define if it is normal delivery, any loss of blood that is over 500, and if it's cesarean, if it's over 8,000. Then the causes could be tone, tear, tissue, or thrombin, and the commonest is usually uterine atony. The woman has delivered, maybe the placenta is still there or is already, but the uterus is not contracted, because so the uterus is atony and a lot of blood is gathering, or there could be tear. Even sometimes is not even ruptured uterus. I'm sure in this room, with all the people that have experience, even common episiotomy can end up with severe PPH, somebody who is not, or even vaginal laceration or perineal laceration. All of these can end up with very severe postpartum hemorrhage if they are not well managed. Not to talk of when you have cervical tear from a woman who probably was not cooperating, and before full dilatation has decided to push, and then any of the delivery tracts can cause all these challenges. Now, retention of tissue can be retained placenta, even membranes. Ordinary membrane, if it's retained, can cause all of this. And then thrombin, either from when you have already had a lot of the bleeding, which has not been checked up, which has not been checked, or you have other causes which can deplete all the clotting factors which you need to manage. Now, what are the practical steps? In simple terms, one of the commonest things that even before the doctor will come, we should always tell them, you discover that this uterus is not contracting, even before you run for your osteotics, before you run for the misoprostol, put a rub on that uterus. Rub the uterus, and as you stimulate the uterus, it will start to contract, because that's the way God has done it, has made it. So we need to do that. We need to also teach our nurses or our helpers that that's the first thing. Then you go for all the osteotics, you go for misoprostol. The coming of misoprostol has put some revolution even to obstetric practice, and the good thing about it, as we all know, you can give it orally, you can give it vagina, you can give it rectal, and whichever route you decide to use, it will always work and it will always help. And for a number of in practical practice, which will be very useful to you and me in our practices, is that when you know that a woman will probably have postpartum hemorrhage, maybe because of the multi-gravity part of her history. You could go ahead, tell your nurses, as soon as this woman deliver, put in misoprostol. Everybody can recognize the rectum, and they can put 1,000 microgram into that. And routinely in most places now, even after cesarean section, apart from all the oxytocin you have put in 4 tablets of misoprostol rectally, and it has done a lot of help in ensuring that having to run around middle of the night after you've done the CS is no more there, unless there is actually a real problem which you need to solve. But if it is atony, when you take all of those precautions, misoprostol is doing a lot of this help, and we should make sure that it's available. It's one new drug that has moved from just being a gastric peptic ulcer drug to a very important obstetric drug. Then you go ahead to remove retained placenta or retained tissue, as we have said. When you have retained placenta, we all know is a very common feature in our environment. In most instances, all you need is ensure that you get the woman relaxed. It is not the best struggling with this on the bed. Take the woman either to your theater or to the delivery room. If possible, put her in lithotomy position, set up pitocin, put your misoprostol. That uterus will contract, and you get yourself ready to put your hand into that uterus. And if the woman is well relaxed, you should be able to enter the uterus and then bring out whatever is there. It's always important, even if the placenta is off, to ensure that you correct it, and it gives opportunity. One of the greatest opportunity such step gives to us is that you are able to examine right from outside to the vagina to the cervix itself, even before you put in your hand into the uterus, either to remove the placenta or to bring out whatever is the retained product that is there. All of these are very useful things to do. Then repairing of cervix. These are very important skill that we must have within our ambit. All you need is to ensure that you have sponge holding forceps, minimum 2, and then you pick the uterus, the cervix from, you can start from 12 o'clock and then move clockwise until you go round. Wherever the cervix is lacerated, you are going to be able to see it. And as long as those two forceps are on both sides, you will be able to control the bleeding, and you'll be able to now do your repair without much distress. As I said, it's always important to be able to put in lithotomy position. Getting things to be in lithotomy position, even in the rural place, should never be a problem, and we should ensure that we can do that. And our simple, now that the baby is not there, you can use your pentazocine with diazepam, and that in most instances may be sufficient. You may not even need to go ahead and be using ketamine before the woman will cooperate, and you'll be able to do all the necessary repair. As we said earlier on, right from outside, from the vulva to the vagina to the cervix, any of those ones that you find that is lacerated, you can always do it. It's also an opportunity for you to examine the uterus. Sometimes you will say yes, we've had a spontaneous vaginal delivery, but this pph, after you've discovered that you have removed all the products and you could not find anything, could be possible that even the tear on the cervix, or you didn't find a tear in the cervix, there could also have been a silent rupture of the uterus. I've had occasion that yes, after I put my hand inside, I discovered my hand was now touching the abdominal wall anteriorly. That shows that something has happened. So you just go ahead, open the woman, and then you don't even need to remove the uterus. All you need is repair the uterus. In most instances, when you have ruptured uterus, even when we get to obstructed labor and you have ruptured uterus, the key thing that you need is not necessarily that you should look for your skill to remove the uterus. If you are able to repair the tear very well, you have done the woman all that she needs. You can keep her alive and be able, if you think you are not feeling comfortable, at least your repair will keep the woman to be able to be transferred to wherever you think, if you feel that yes, this uterus still need to come out. But you must be and the repair of the uterus is not more than 2 layers. You get the edges together sufficiently, 2 layers. You can use the almighty chromic number 2, but these days most people will want to say yes, you must use Vicry, but chromic is still useful. Even in some places, fish line is still useful. So those are just what we will concentrate on. And finally, you can also pack the uterus. My boss in Kogi State was even doing a cesarean section. That was my first time of seeing it, and the pph was so much that it was placenta previa, I think type 4. It was not the days of scan that you can know that before you go in that yes, I'm dealing with placenta previa type 4. And at the end of the day, when he knew that yes, if I do not do something, I'm likely to lose this woman, he went ahead and packed the uterus. And once or twice we've also had that opportunity to have to pack the uterus, even in Ibadan here. We pack it, and then 48 hours after we went back to go and remove it. So don't be afraid if you need to pack, and then you suture what is possible to suture. Pack, even after you finish, you can still pack from below to add to your packing there as much as possible. But things like B-Lynch stitches has also helped in working in saving the women even from your needing to pack. But if you are in a place where you don't have such skill, go ahead and pack. WHO also agrees with it. Yes. Hypertensive disease, we will not dwell too much on this. It could be chronic hypertension you are dealing with, preeclampsia or eclampsia. They could all be superimposed on the chronic hypertension. It could be gestational induced hypertension. The key thing here is not for us to debate whether it's the egg that came before the chicken. What is important is yes, what is the level of the blood pressure that I'm seeing in this woman, and what is her gestational age, and what am I to do? Let's go to the next slide. Now, what we are to do is for us to know that these are the few antihypertensive that are useful in pregnancy and in obstetric care. When you have had a woman who is been hypertensive even before pregnancy and has been on things like lisinopril, amlodipine, and any of those other things, it is advised that you change. That's the key issue. And for us, in our own resource poor area, let's take note of this. Whatever the woman has been on before, change to these ones that are well known across the world, that are safe in pregnancy. And when you change to them, at any stage of the care that you are going to give the woman, you will always be safe. Even for emergencies in preeclampsia or very severe preeclampsia or even eclampsia, we should all know that the other ones are not very much advised. Next slide. So whether it's severe preeclampsia, this is what we should do. Labetalol, whether oral or IV, when it's severe, nifedipine or metidopa, because we know that some of them will even come even at their booking, and we may have to take care of them. Sometimes, even as you are seeing the woman in the clinic, sublingual nifedipine will help. As they are measuring and they are saying, oh, this woman's blood pressure is 180, 100. Just say, madam, put this 20 milligram nifedipine under your tongue. Before you complete most of the other things, you are doing scan, she's going to the lab to check other things. Before she comes back, that blood pressure will already be getting abated, and you're already solving her problem. But if there is need, next slide. If there is need for you to prevent seizures, we all know that magnesium sulfate is what is recommended. And in any situation in which you are having severe headache, getting compromised, we must ensure that we go ahead and do something better. And if we have access to laboratory, checking their creatinine and uric acid is also very, very critical. And they can tell us that we need to go ahead and use magnesium sulfate. Next slide. Now, this is the practical part of magnesium sulfate. Can use it intramuscular, 2 stages. Your first loading dose and then your follow-up. The same thing in intravenous. Your loading dose, 4 gram IV, 5 to 15 minutes, slowly, or you can even put it in a 500 minutes IV and let it just run. And then you continue with the infusion. And then you take note that you have to wait until after 24 hours that you don't have feet before you stop it. So these are just practical things for us. It doesn't need any falutin one. Pick the one that is convenient and the one you think you can practice. But key thing in pregnancy complicated by hypertension, preeclampsia, is for you to, or even eclampsia, what do you decide to do? Some of them, when they come in emergency, they are even already in labor, and all you need to do is check. And if you think that you can augment and have a spontaneous vaginal delivery, please go on. It's not always that you must do a cesarean delivery. But if they are not in labor, you have to consider, you check the service and you know, yes, this service is probably an impossible one. And before you can deliver that baby, maybe there will be challenges. So you go for cesarean section. And as we said, these are the people that are due even for assisted vaginal delivery. After you've augmented, you know, this woman will not be able to okay. So we must ensure that because the woman may already not be able to push and may not be able to do. Are we okay? Are you good? So have to go ahead and possibly do a forceps or a vacuum. But whenever it's necessary, we must shy away from doing a cesarean delivery. Next one. Come to one of the commonest challenges we meet at the in the rural practice. This is obstructed labor. I have several definitions here, but what I always say is that obstructed labor, you define it as when there is poor or no progress in spite of good uterine contraction, and then in most instances nothing will happen unless you intervene. Okay. Oh, this side. All right. So unless you intervene, so now the epidemiology of this is that it's known that 3 to 6 women globally will have obstruction, and it accounts for close to 8% of maternal deaths, and in very common practices, close to 10% of our in most time and in most busy maternity center, you are dealing with obstructed labor. Next slide. Now, our own key thing is to know that obstruction can always come when there is cephalopelvic disproportion, especially when you already see the size, the height of the woman. When there is malpresentation or malposition, and the commonest complications are sepsis, stillbirth, postpartum hemorrhage, uterine rupture, and maternal death. Now, the key issue for us as practitioners is that when they come, what do? We must know that, like, please, must know that if we examine and the condition any of these are still possible, we should go ahead and try them. Let us not say no, this obstructed labor, she doesn't need vaginal examination, take her to theater for cesarean delivery. Let us check and see what can be done. Even those who are within our own premises, the nurses have been monitoring and they have informed you that she's already fully, but she's not pushing. When we get there to assist, let's check if for all of this almost the same condition, which I've tried to put in very simple ABC or mnemonics. Before you can do any of these assistance, ensure that you call for assistance. It's not a delivery for a single individual. You need 2-3 people. Then B, ensure that you empty the bladder. Sometimes the full bladder is what is not allowing even the head to come down. So catheterize, empty the bladder, and immediately after you've done that, check, be sure that the cervix is fully dilated. Sometimes even for vacuum, all you need is either 8 or 9, may not even be up to 10. Just the anterior lip being there, you can push it back and put your cap, the cup of your vacuum. Then D, which device have you decided that you are going to use? Whichever one, apply it. And immediately after you have applied, decide whether you are going to need episiotomy. You know that in today's practices, even for normal deliveries, for primips, talking of episiotomy is not compulsory. You have to assess the woman whether she needs it. It's only what she needs you give her. If the place is roomy enough and the baby can come out, you may not need episiotomy. But it's very critical more in all of this because these are instruments, especially the forceps. You know that it has to come out widening the perineum. So you put the episiotomy at that level, and then your next one is you apply the force, and you apply it 2-3 minutes. Ensure that you are ready to give up. When you have done 3 applications and the thing is coming off, you need to go ahead and change your step. So after that, let's go to our last and most important procedure in obstetric practice in emergency situation. The indications are listed: maternal side, fetal side. Yes, the people we have are not medical students. All of these are what they have seen before and what they have done before. Now, let's just remind ourselves of the steps, because those steps are very critical. There must be very good preoperative preparations. We must ensure that a woman that is coming obstructed, you put sufficient IV fluid and hydrate her, and put catheter. Be sure that she's making urine. In instances when you cannot do E&U creatinine, as long as you put on sufficient fluid and the woman start to make urine, it gives you peace that this woman's kidney is functioning well. So that is part of the preoperative preparation. For us, those are critical more than shave the woman, take consent. Very, very critical, but this life-saving preparation. The anesthesia that you are going to use, decide which one is convenient for you, whether it's ketamine IV. If it's hypertensive, you should not do that. You may need for you to do a spinal, but I can tell you local anesthesia is good enough to do cesarean section, and I've had to do it in a few occasions. All you need is every stage you put anesthesia, and I would advise that the vertical incision and the anterior wall when you need to do that, especially if you have a woman that has hypertensive problem and you know that you don't have the skin for spinal, but you must do this cesarean section. Infiltrate vertically as you see along that line. Then after the skin and you have entered, also infiltrate the lower segment of the uterus, and you will do your cesarean section comfortably. And after you have delivered the baby, you can now put in your ketamine or put in your diazepam and pentazocine, and the baby will come out good enough. And it's very important that even in our rural practice, let us ensure that there is oxygen, because that's one of the things that will keep the baby alive and also sustain the mother. And in this day and age where there is oxygen concentrator, they are not too costly. And in fact, there are even NGOs that are ready to partner with facilities and be able to supply it to them. So getting oxygen source is a very critical thing for all form of practices, even within a rural center. So that's anesthesia. Operative procedure, we have mentioned part of it. Your skin incision, your incision on the uterus. The incision on the skin can be any of these ones. Those are for academic. Is one of the areas where we must be prepared for. Caution must be taken before you put your incision on the uterus. It's good enough for you to check where is the head of this baby. Is it very deeply engaged? When such happen, get one of your experienced nurse to be ready, glove ready, that can push that head up for you. Because sometimes when you yourself you are struggling to push and to pull up, you could end up tearing your incision to the side, and you now end up with the uterine bleeding very severely. And if you are not very experienced, that may create a lot of problem, a lot of panic. But if they help you to push up, it will help. The other thing that you can do is, if peradventure you don't have such people who can do that for you, an inverted T is still possible. You have done your lower segment, you can also put another incision directly in the middle of the uterus, what used to be known as classical incision. All of them will heal very well. I've had to do it on several occasions. Put it in the middle, so you now have an inverted T incision, and by the time you push your hand down to deliver that baby, you won't have any tear to the edge. All you need to do is just concentrate on your incision and close all of them, and they will heal very well, and there will not be any problem to it. Then uterine closure, as we have said, your number 2 chromic is also very good. 2 layers, or in modern days you can do single layer, but you have to be sure that you take all the edges together. My brother and friend is not here, Dr. Ogushe. One of our residents we sent to him, he was still doing the need